everyone. Thank you all for joining us today. My goal or my purpose is to kind of discuss some of the ways that we treat peritoneal surface malignancies, particularly with the use of intraperitoneal chemotherapy. As Glenn mentioned, I have been performing surgeries for peritoneal surface malignancies for a while now and using Hipec. It's about 15 years of my career so far. And I have just come to Stanford after spending some time in a different institution. And we have opened up our Hipec Center here, which has been a great change for me. Excuse me. So I'm going to speak about a few things today. First of all, just giving a broad overview of what Hipec is, or what treatment for peritoneal surface diseases is, why we do it, some of the results of the diseases that we take care of. And, you know, again, I'm not going to go too in depth. This is more for patients rather than a sort of a scientific type of discussion, but just want to sort of go over some of the results that we have. And more get to why we do these things, how we select patients, and advice for patients who are looking into this treatment or being considered for treatment by a Hipec surgeon or Hipec team. And obviously, I'd like to leave room for questions and answers at the end. So, peritoneal carcinomatosis or peritoneal surface malignancies are quite impactful for patients with GI cancers. We know that about 10 to 15% will have peritoneal implants at the time of their diagnosis. And this can be whether the cancers are involving the serosa, which is the lining of the organs or lining of the abdomen, bowel perforation from the cancer, or in females, metastasis to the ovaries and fallopian tubes. We know as we treat GI cancers and follow them after treatment, about a third of these patients will actually have their recurrence or metastatic disease in the peritoneum. So it, for many of us who have treated these patients, it becomes almost an organ in itself. And that's how, that's where the idea of surgery and Hipec came from. This is just a schematic of what peritoneal metastasis is. And in this setting, we're using stomach cancer as a sort of an example. We begin with a primary tumor, and this grows enough so it begins to invade the lining of the stomach. And once that happens, the cancer cells can potentially detach. Now, the peritoneal cavity is almost like a barrel, where the organs sort of sit and float in peritoneal fluid. So with that, the cancer cells can detach, float through the abdominal cavity, and attach to certain areas like the peritoneum, where they can set up shop and form new areas of tumor and metastasis. Obviously, for certain cancers, if left long enough, these cancers can break through and invade blood vessels and lymph vessels. So it's sort of a fine line of where we catch these tumors and whether or not surgery on the peritoneal cavity can be effective. Historically, this has been a pretty poor prognosis for patients. You can see in these mostly medical oncologists, so chemotherapy studies, that most patients who are affected with peritoneal metastasis from colon cancer had a very poor prognosis. So median survival of less than 6 months. And a more modern look at it is a median survival of 12.7 months. So about a year of survival just with systemic chemotherapy alone. A lot of these are familiar to patients who have gotten chemotherapy. FOLFOX is pretty much a standard regimen for most GI cancers. And you can see patients who have peritoneal metastasis from colorectal cancer, if they're given FOLFOX, even in the modern chemotherapy era, median survival is almost a year and a half. With FOLFIRI, which is almost always second line or different line of therapy for patients who can't tolerate oxaliplatinum. You can see that patients have even worse median survival. And notice in the curves too, from this and the previous slide, that peritoneal metastasis almost always has a worse prognosis than non-peritoneal disease. The idea of Hipec, or delivery of heated intraoperative peritoneal chemotherapy, is not new. We've had this technology, or have been performing this for many years, particularly Dr. Sugarbaker, who pioneered and pushed most of these efforts in the United States. But you know, it has become a more recent treatment option for patients as more and more studies are coming through. Why intraperitoneal chemotherapy? Well, obviously, if we place the chemotherapy in the peritoneal cavity, there's going to be better distribution of the chemotherapy drugs. There's going to be more bioavailability of the drugs. And the use of hyperthermia, or heat. Well, heat alone itself has anti-tumoral effects. We know that if you heat chemicals, obviously the reactions are better, so it can enhance the performance of the chemotherapy drug. And also by heating the abdominal cavity, we potentially increase the drug penetration. So these are sort of the theories or the ideas of why heated intraperitoneal chemotherapy, or Hipec, works as a therapy for peritoneal surface cancers. The problem, or what happens with patients afflicted with this disease, is that, you know, as you can see from this list, it's a large amount of disease states that can metastasize to the peritoneum. And each one of these potentially has a different treatment or different schema of treatment. Some are very low grade or slow growing, some like Epithelial and Mesothelioma. These cancers do respond quite well to surgery and heated intraperitoneal chemotherapy. Others that are more aggressive, like pancreatic and hepatobiliary cancers, are not as effective, and therefore, you know, even as we evaluate these patients for potential Hipec, we tend to steer them more towards systemic treatments and not surgery. But again, I think this is sort of the problem faced with patients with peritoneal surface malignancies, in that, you know, it's not just one-stop shop. You don't just go to one doctor and you get one sort of treatment. I think, you know, you really have to go to a center of excellence that knows how to treat each site and knows the potential options for each site. The first part, or, you know, what patients think of Hipec is not just the chemotherapy alone. It actually is quite a big or extensive operation. And the idea is that we're going in and trying to treat all of the disease that we see on the peritoneal surface. The big term, or the medical term, is cytoreductive surgery, but most patients often hear just debulking. And the idea is that we have to, as surgeons, look throughout the abdominal cavity, debulk all visible tumor. These can require multiple resections, and I think oftentimes patients are not prepared to hear these things when they come in for their consultations. You know, we have to do peritonectomy procedures where we strip the lining of the abdomen and strip the lining of organs, potentially remove segments of large and small intestine, potential removal of the gallbladder, potential removal of the spleen. And in females, oftentimes a hysterectomy or oophorectomy are advised. Given all that, and then the addition of chemotherapy, these can be quite extensive procedures. 8 to 12 hours is often what I tell patients, some less, some more. But again, this is not a small surgery. This is not something that is done on a basis where you take it lightly. This is just a cartoon, so obviously we're depicting cancer nodules throughout the abdominal cavity. As I mentioned, surgically, our idea is that we're going to cytoreduce or debulk all the visible tumors, so we don't see any large tumors anymore. But obviously, if we have big tumors, we probably have small cells that are still floating in the abdominal cavity, still attached to the organs. So these are the ones that I can't treat with surgery. You can't see these. There's no microscope. There's nothing that I can really do to kind of depict these things and remove them or ablate them. So that's where the idea of Hipec comes. Still heated chemotherapy into the peritoneal cavity. And that heat goes to about 103 degrees, so a pretty high fever. Agitate the abdomen, so hopefully the chemotherapy is perfusing and distributing throughout the belly, getting in between all the different crevices. And then the chemotherapy is drained, and this is sort of an important step as obviously we want to reduce the amount of side effects, the amount of potential complications from the chemotherapy. So the goal is to sort of remove what's been instilled in the abdominal cavity. And obviously at that moment, we're finished with the procedure. A big graphic, but we go from something that looks like this, where there's tumor everywhere, and we're trying to our best to get this tumor and this mucinous ascites out, stripping all the surfaces so we see just bare muscle and bare organs. And again, removing everything down, and this is what we call optimal cytoreduction, or removal of all visible tumor. These are just intraoperative pictures of what potential Hipecs look. This is more of what I do. We call this a closed technique, where there are catheters that come in and perfuse the chemotherapy to a machine. That machine keeps the temperature of the chemotherapy constant and keeps the flow of that chemotherapy constant, so I know that we're getting good perfusion. This is called the Colisseum technique. This is performed by some surgeons and some other sites where the abdomen is actually left open and the chemotherapy is instilled. This allows the surgeon to manually agitate the chemotherapy and potentially still do some of the cytoreduction as the chemotherapy is being perfused. Again, this is just an intraoperative picture showing us how we perfuse and do what we call shake and bake. How do surgeons choose the right patients? Again, this is a big operation. You have to be medically fit to undergo the cytoreduction and the Hipec. Traditionally, patients were sent to us if they had extra abdominal disease, if they had liver metastasis, if they had big bulky lymph nodes, or retroperitoneal disease, we would not do or not consider doing Hipec. But I think the most important thing is that all peritoneal disease must be resectable to minimal. So over the years, I've started to do Hipecs in patients with liver metastasis as long as I can take the liver mets out. Lymph nodes, again, if I can remove the lymph nodes at the time of surgery, typically we try or attempt cytoreduction Hipec. And in some patients with extra abdominal disease, certainly patients who have colon cancer with limited lung metastasis that's controlled on chemotherapy, I would consider it. But I think the one that still remains to me is bulky retroperitoneal disease. These are patients that I know that surgery is not going to help, and Hipec definitely will not help these. You'll hear a lot about PCI, or peritoneal carcinomatosis index, from your doctors, and it's just a way of doctors to communicate to each other how much tumor or how much disease there really is. Basically, it goes from 0 to 39, 39 being the highest score you can get. And it separates the abdomen into different areas and scores your tumor based on size. Obviously, the lower the number, the better, meaning more of it can be removed. The surgeon can be pretty much successful in bringing it down to minimal disease. The other number, or the other thing that you might see on your medical consultations or operative notes, is completeness of cytoreduction, or CC score. CC0 means we've taken it down to nothing. You can't see anything. And then obviously the higher you go, CC3 means that we're leaving bulky tumor behind. What we call an optimal cytoreduction is obviously CC0 or even CC1. Anything greater than that the chance of Hipec being effective, or the chance of the intraperitoneal chemotherapy being effective, is less and less. And the reason is because the chemotherapy cannot penetrate this size of tumor, and therefore is non-effective. So often, if we can't get this down to 0 or 1, we really will consider or probably not do the Hipec at the time of surgery. So this is always my favorite, is that, well, we talk a lot about it, we show a lot about it. Does it actually work? This probably was the biggest trial that came out that sparked interest in Hipec. And it was for colon cancer, looking at the standard of care back then, which was palliative chemotherapy. And granted, it was old chemotherapy, meaning just 5-FU, but it was the standard of that time. And then it looked at using Hipec, heat intraperitoneal chemotherapy, cytoreductive surgery, and then following that Hipec session, patients would try to get systemic chemotherapy as well. And this was the first randomized trial that was put out that did show that Hipec increased or improved the survival of patients with metastatic colon cancer. You can see it almost doubled the median survival. And with the curve, you can see that there are some patients that survived 3 years or more, and even 5 years or more. As time has gone on, and obviously Hipec and cytoreduction is being performed by different centers, more and more centers, I think the conclusion, or can we really use this modality to actually help patients, and are patients quote unquote cured? I don't like to use the word cure necessarily for stage 4 cancer, but in this nice study of looking at one center's experience in France, you could see that patients who were treated with cytoreductive surgery and Hipec for colon cancer, approximately 16% of them were without evidence of disease 5 years and more. So these are patients who are potentially cured. So I think, again, it's showing that this modality definitely can help certain patients. A more recent study that was put out for ovarian cancer. Now, obviously, ovarian cancer is shifting a little bit from the colon cancers, but definitely one of the cancers that we treat the most in the peritoneal cavities, because ovaries float in the abdominal cavity and definitely shed cells to implant a lot earlier than other cancers. And you can see that the use of Hipec surgery and Hipec improved the survival in these patients. All of these patients received chemotherapy up front, and then were either followed by surgery or followed by surgery with Hipec, and it improved recurrence-free survival and also improved overall survival in patients with ovarian cancer. And I think a lot of us have taken this data and definitely applied these techniques for patients with ovarian cancer and offered this as treatment. Gastric cancer, it's a malignancy that I treat quite a bit of, but when we talk about peritoneal metastasis from gastric cancer, traditionally in the United States, this was often a condition that was end stage, palliative. As the experience of Hipec has increased, we obviously look for other treatments for patients who have no further options. And this particularly is for stomach cancer. You can see in this, the curves don't separate that much. So we were not that optimistic about this. But when you separate them down, and I know that we're not supposed to separate these patients that much, but you can see that in this line, if our completeness of cytoreduction, or if our ability to take all the visible diseases there for stomach cancer, patients did well with cytoreduction and Hipec. And if they had limited disease or low burden of peritoneal metastasis, again, if you follow this line, so patients with a PCI, again, that index of how much cancer we see, if it's relatively low and we're able to remove all of it, these patients do quite well. So again, I think for certain patients with stomach cancer and peritoneal disease, if we're able to remove all visible tumor, there's really not a lot of cancer spread in the abdomen. I think Hipec becomes an option. Peritoneal mesothelioma, rare. It is 1/3 of all mesothelioma cases that we see in our country. So that we were more familiar with the pulmonary form, plural form. May not be asbestos related, but you know, obviously a lot of our patients have been or are exposed to asbestos. In this particular cancer, really the subtype is what drives treatment. The epithelioid type, which is the lower grade, this responds favorably to cytoreduction and a Hipec. You can see in this table of patients with mesothelioma treated with Hipec, the median overall survival, typically over 25, 30, 40 years, even one more than, I'm sorry, not years, months, even one with greater than 100 months of median survival. So again, I think this is a disease that does respond favorably to surgery and Hipec. At Stanford, we are opening up our mesothelioma program and definitely performing cytoreduction of mesothelioma in the peritoneal cavity and eventually moving this to the chest cavity as well. Are you a candidate? This is always sort of number one. All the emails that I get from patients and family members are the candidates. Number one is always what type of cancer. I think appendiceal, certain colorectal cancers, ovarian cancer, mesothelioma, these patients should be considered and should be evaluated for Hipec. For pancreatic, stomach cancer, some of the liver and biliary cancers really have to be a little bit more cautious, and I think those are more on a case-by-case basis. And you know, those should be seen, but need to understand that they may not be candidates for Hipec. Medical fitness, this is a big one. I think if you're unfortunately not in great shape, if you're having a really hard time coping with the cancer or the effects of the cancer, this is a big burden on your body. And I think, you know, most surgeons, most doctors would not place patients who can't, who don't have a good performance status as a candidate. The amount of disease, as we talked about, you know, the PCI or how much disease we actually see is important. Your doctor, your surgeon is going to evaluate your scans, evaluate CT, MRI, PET, whatever it is that has been ordered for you, and really looking down as to see where is the cancer, where is it, can I take it out, can we take it out safely, and are we going to affect your quality of life? I think that's the most important thing, is that, you know, obviously, yes, we can do all sorts of heroic surgeries, do all sorts of things, but if I'm not returning you to some sort of baseline or some sort of normalcy after surgery, then the sort of the treatment is probably not the best thing. Excuse me. Type of spread, if what we mentioned before, if we see lots of extra abdominal disease, if we see lymph nodes outside of the abdominal cavity, if we see bulky retroperitoneal disease, these probably are not going to be cancers that can be treated with Hipec. Seek a peritoneal surface malignancy center early. I think that's probably the best advice. These are not common. Even if, you know, you're with a surgeon that you like or a medical oncologist you like, you know, you really have to sort of go to where patients are treated and have doctors that see this on a regular basis. I can't tell you how many times we have seen potentials for treatment early that have been delayed due to sort of not knowing that you can do surgery for certain patients and not knowing that intraperitoneal chemotherapy is an option. So I think it's important to seek these centers early. minimally invasive surgical techniques can be utilized. I think this is what everyone wants. You know, they want small incisions and think that it's fast recovery or you know, that they can get back to their life. I will say that we do them, but it is less often than we want. As we kind of mentioned, we have to look in every single quadrant of your abdomen and work on every organ. So even though we can use laparoscopic and robotic techniques, not every patient, and I would say a majority of patients, will not be candidates for that technology. What to expect? These are long cases. You know, patients, families have to understand that, you know, it's not how fast I do the surgery, it's how well I do the surgery. You know, I think sometimes people equate, he or she took a long time, that this is, you know, they didn't know what they were doing or didn't, you know, weren't doing a good job. I would have to say if I'm doing short cases, that means I'm probably not doing a good job. I think, you know, really you have to be thorough. You have to be able to remove and look at all the different areas and make sure that those are all clean at the time of Hipec administration. You may stay in the hospital long. This has been particularly challenging in this COVID-19 era. Patients are in the hospital, unfortunately, mostly with just the hospital staff. Not being able to have their family come in and visit with them is devastating. We all know it. You know, at Stanford, we try our best to occupy the patient's time with other activities, and obviously virtual visits with their family members is done, and you know, we try our best to keep that. Tubes and drains are common, and I don't know if any of you have had surgery, but you do know that potentially drains are essential in making sure infections and bad fluid is pulled out before they can cause problems, and that's why I use them quite a bit. They're reversible, removable, but I think patients wake up and oftentimes look to feel what's different in their body, and these can be one of them. I discuss ostomies quite often. Not every patient needs an ostomy. Most of the ostomies are temporary and reversed at a later time. But you know, again, if we're going for a chance of control of cancer and we're being aggressive, I think ostomies have to be discussed. This is always the hard part of any consultation and visit for certain patients, but you know, I think that's important to talk about, and you should ask your doctor or surgeon about that. Being that this is a lengthy and complicated surgery, there's always a chance of complications. And this doesn't necessarily mean that anything went wrong in the surgery, but if you're operating on multiple sites, multiple different organs, each one of those organs has a chance of complication. And you add those all up, and at the end of that, you add chemotherapy and heat, and you can potentially make a problem with wound healing, and complications can arise. We've definitely gotten a lot better with Hipec over the years. I think it is a much safer surgery than the initial attempts at it. You know, back in the late 80s, I think we definitely have come a long way, but there always is a chance of complications. And again, your doctors should discuss that with you. I think the hardest part for patients is not taking in food. And this can be for quite a while after Hipec surgery. I often will tell patients, you're probably not going to have anything substantial for at least 5 days, maybe liquids, maybe nutritional supplements, sometimes even IV nutrition. But again, that's an important thing to understand ahead of time. That way there's not such an expectation that you're going to be in and out of the hospital in a few days. I think that this, again, is a long recovery and long haul, and I think patients need to be prepared for that. The last point, you will likely require additional chemotherapy. I think a lot of patients come in with the expectation that surgery and Hipec is all they need. That's not true. I think for some patients with a low-grade appendiceal tumor, that might be the case. But you know, if you have colon cancer, if you have ovarian cancer, if you have even mesothelioma, Hipec and surgery is just a part of your treatment. I think oftentimes patients who do well, do better, are the ones that can move on to IV chemotherapy afterwards, and potentially have a much better improvement in their condition and survival. How do you find treatment? I think the best is using patient advocacy groups. Colon cancer patients, GYN cancer patients, I know have great advocacy groups for the pseudomyxoma peritonei. I know several that are great in helping patients understanding their disease and understanding where to find the treatment centers. Certainly hypectreatment.com, which I know is how you found this webinar, is a good advocacy group, and I think these are important. The internet is great. There's a lot of excellent material, a lot of educational material, but I think there's a lot of bad material. So please use caution when using the internet. I think, again, use the advocacy groups, use the true cancer care sites, and I think that will help you decide on what treatment is best and where to seek it. I always tell my patients, even if they see me, request a second opinion. I think it's important not to hear from just one person, but from multiple people. I'm not saying see 4 or 5 different surgeons, but you know, definitely 1, 2, even 3. It's important. I mean, this is your life. This is your well-being. It's your family's well-being. And I think if you know, you get the experience, you get the opinions of multiple people, that will be the most help. This is not a surgery that you come out of training and do. I think the experience of your surgeon and team is essential. There are so many nuances and so many different things that we do in the operating room that are important. So again, I think understanding who your surgeon and treatment team is or are should be one of the checklists under your things for finding your treatment team. And unfortunately, a lot of patients are not going to be candidates for cytoreduction and Hipec. I don't think you should, you know, necessarily feel that that's the end of it and that you shouldn't have any more treatment. I think we often will have different options, whether it's a clinical trial, whether it's more systemic chemotherapy, or whether it's a palliative medicine trial. I think centers of excellence will have different options for you, even if you're not a Hipec candidate. So I think, again, this sort of reiterates the importance of finding a good team, and not being too disappointed that you will not be a candidate, because again, it is not every patient that will be able to have this surgery. So to conclude, move on to the questions. You know, the treatment of peritoneal surface malignancy has progressed quite a bit from a palliative type of treatment to one of potential cure and control. I think surgery with intraperitoneal chemotherapy improves survival for certain cancers. We all know that clinical trials are needed, and if we can produce more Hipec or intraperitoneal chemotherapy trials in the United States, we would love this. New therapies are emerging, new strategies are emerging. And if you follow me, I'm definitely trying to push newer strategies of delivering intraperitoneal chemotherapy. And this is something that we all are striving for in the US. Seek help early. As I said, you know, this is not one where you kind of just told your diagnosis and go. I think you need to definitely seek opinions of experts and seek opinions of centers of excellence. Despite the stay-at-home orders, we certainly are connecting with different patients throughout our communities, and the telehealth communications and telehealth technologies are definitely helping us. So even at this time, it's easy or possible for you guys to get in contact with us. So please seek help early. Don't wait till you've exhausted all options before talking to somebody. So this is my contact and the number for the surgery center at Stanford. And I'd like to open up to your questions and comments.